Hi, this is Nurse Cecilia here, and today we'd like to talk about pain. So, how many times we're looking after this patient who underwent cardiac and thoracic surgeries, and pain is very important to keep assessing all the time on this type of patient and try to keep those pain levels as low as possible. So, we're going to talk about this later, but we are going to benefit the patients of further complications and have much better experience when they are in the intensive care unit. So I hope you like it and take all this information with you. This is a lot of sample I put out there, and I hope you enjoy it. What happens when a patient is experiencing pain? Pain inhibits satisfactory coughing and deep breathing, and patients in pain breathe more shallowly and rapidly. This results in mucus accumulation and puts patients at risk of atelectasis and pneumonia. Consequently, prolonged hospital stay, mechanical ventilation, and antibiotics. So effective pain management depending on three things: effective pain assessment, type of sedative, and analgesic administration. Working in an intensive care unit could be overwhelming and stressful. So we can do a few things to reduce our stress and anxiety, just to provide better care to that patient and to minimize mistake as well. So I like to, when the patients come from the theatre room, I like to know the background of the patient, and I like to, when I have the anesthetic records on my hand, I like to read what pain relief was giving and whatnot. And also I like to have the pain relief ready to be administered to the patient. So those things, it could help to minimize the stress and anxiety and have things prepared in the intensive care unit is useful for me, is what I like to do. Signal pain on sedative patient. Very challenging, I reckon. So mainly, I'll try to see the facial expression of the patient. Sometimes they're grimmed, and it's amazing how when you look at them, you can see they're in pain, but they're asleep. So very, very good observations, nursing skills there we need. And also when they move a little bit, the limbs, upper limbs, they could be a little bit twitching or something. It could be pain manifestation. And also have a look at if they ventilated, of course. Have a look at the ventilator, if they in synchrony with the ventilation. Sometimes the patient trying to breathe out when the ventilator tried to give it a breathe, or sometimes it's just a little bit of resistance there on the ventilation. You can see, so the ventilator trying to deliver air, but the patient's, getting intrathoracic pressure, so the air doesn't go in. Could be a sign of the patient is unconsciously asleep, but unconsciously having pain. So it's a tricky one, but I think it's a good one if you observe the patient more closely. But to me, my experience, the facial expression is one of the top three to look at. I think patients gives away when they are asleep, and the facial expression gives the pain away when they are asleep, in my experience. So there's three things when the patient is sedated to look at about pain. Of course, you have your pain relief ready, so time to give pain relief. The main pain signal when the patient is awake is going to be the patient telling us they are in pain. So, but how we are going to assess this pain? The experience and expression of pain are influenced by a range of physical, emotional, and socio-cultural and existing factors. So pain is subjective to every single patient. In the intensive care unit, we use a good tool that you can see on the slide there, that is called the VAR tool. So we can score the pain 1 to 10. I make sure I use this VAR tool hourly, and I give pain relief accordingly. I would like to share this experience with you when a patient was 2 hours post-op extubation and he was with his eyes closed. He seemed to be asleep. His BP and heart rate were high. So I asked him using the VATS tool, how much level of pain was he experiencing? He answered was 5. I administered more pain relief and his BP and heart rate started to look better. So what I took from this experience is sometimes, due to the surgery itself, the patient cannot figure out what is going on. But when you start asking questions and I him, he was able to tell me he was in pain. I would like to mention as well that a patient who develops delirium in the intensive care, it could be pain, due to pain. I don't want to dive into this too deeply, as delirium is a big subject in the ICU, but it is something to think about. I make sure I administrated the Panadol regularly as per doctor's prescription the first 48 hours, at least, regardless the pain score is. I have experienced patients not want to take any Panadol after surgery, but I said to them that it is good to take Panadol to be on top of the pain. Again, I said it before, pain is subjective to every single individual, but I look after this type of patient all the time, and I believe giving Panadol regularly, it has helped them a lot based on my experience. Other point I would like to address here is when I am going to do a procedure, not only to explain to the patient what are you going to do, but also I make sure I administrate pain relief in advance at about 20-30 minutes prior to the procedure. So I am sure that pain relief is going to help the patient at the time of the procedure. This is mainly when we're giving oral pain reliefs. Anxiety and pain, I found sometimes they go together very well. It is also important to talk to the patient about the pain he is experiencing and why. I find very therapeutic when I actually explain to the patient what happened to them, mainly those patients who experienced chest pain in the past and were having a heart attack, and now they are now having a coronary arteries bypass. These patients are very scared and anxious about this pain. So in order to decrease the level of anxiety, I literally said to them that they have an open heart surgery, lots of cutting of muscles, nerves and bone were involved, and said to them they're not going to be free of pain, and just is due to, if they experience pain, it's because due to this big surgery they had. It is less likely they're having another heart attack. And also said they are monitored 24/7 while we with them. And so I find the level of pain, it decreases a lot because they will build a trust between us nurses and the patient. So once that we gain the trust of the patient, I experienced once I gained the trust from them, actually they perform better with the pain. So explaining to them what's going on, the environment they are in, and they're very safe. They're saying we are administrating pain relief and we're trying to help them with that. And also it does help a lot with patient pain thresholds in my experience. So I hope these examples are useful for you, and let's see what's next. So pain relief, I just want to mention a few we're using them on work area. Just you check your protocols and procedure in your hospital, and we use opioids as our first line of treatment for pain. And also, as soon as the patient can swallow, we administrate orally because it's much better because we give higher doses and it stays in the body longer. So those things, just to have a glance, those pain relief for you to know. Again, I try to give those pain relief half an hour to 20 minutes before I'm going to do any procedure or when I'm with the patient. So just to make sure they will be in the system, and I'll try to administer those just I think ahead what I want to do with the patient and provide the pain relief just for the patient to be able to do all those stuff we're going to ask them to do. So let's talk about opioid overdose. I couldn't leave this out of this video because it's important when we are administrating this type of drug. So I find patients with pointed pupils and very difficult to wake up as a sign for me that it has opioid overdose. Also, when we do a tear gas, if we have elevated carbon dioxide, there's another sign of opioid overdose because the patient is not breathing up, not clearing up that CO2. Other sign, there's other sign that listed there, but my experience, those three, the most revealing for the patient, in my experience, to have opioid overdose. So look out for those signs and make sure you tell the doctors about it. So last but not least, what happened to me sometimes is I done everything for the patient to control that pain, meaning I give the pain relief, I try to keep the environment quiet, try to explain to the patients what's going on, reassuring all the time. I make sure I tell them when I give the pain relief, I explain all the situation, why he's in pain, and it's normal to have pain in the chest. It's a big surgery he had. He's not going to be free of pain. He's very safe. We're controlling his heart all the time, and the pain's still there, very high. So you have a patient not taking deep breathing and now not coughing properly. So there is a few escalation. You keep liaising with the doctors, talk to them. Look, the patient's still in a lot of pain. What could we do? What our in my hospital, what escalation is also give the patient a PCA, which is the controlled patient pump. So the patient can give himself pain relief. So sometimes that works a lot because the patient, you give the authority to the patient to give themselves pain relief, which is great. And this has a lot of procedures, has a lockout dosage, so they won't get overdosed or anything. Still, be aware of those signs I just spoke before on the previous slide. So what I do is that. So make sure checking with the doctors and is like a triangle teamwork to work to get that patient with lower pain levels. So that's what I do. If you have any experience you want to share with me, comment below. Also, if you'd like me to talk about nursing care, also comment below. And remember, when I'm not sure, I always ask. Thank you for watching, and I hope you have a good day.